Welcome everybody. Thanks for joining the presentation. So we're going to be talking about comfort care today and going through a lot of symptom management, but also talking about history of comfort care and philosophy. I'll get into that in a second. So I'm Zac Erekson. I'm part of the faculty here with the Boise group. And have recently actually moved and I'm practicing now in Utah. I want to give special thanks right up front to Dr. Caroline Hurd, who put together a lot of this presentation originally, and I'm just doing a little update this year. So we're going to be talking about the historical context of comfort care order sets and really, kind of the evolution of some of these, particularly infusions at a lot of healthcare systems. So we'll kind of be going through the University of Washington journey, but that is analogous to kind of what a lot of systems are doing. To do that, we'll be following a patient through their end-of-life course and be talking about other aspects of end-of-life care as well. Talking about the pharmacology and particularly opioid choices, and then a little bit on counseling families at key time points. You have a separate lecture on that, so I'm really just going to highlight a couple things, and particularly with some kind of medical decision-making stuff that may be different from the other lecture that you have. So to start off, what is comfort care? And I want to ask you to take a second and really kind of pause and think about this at the beginning. When someone says comfort care, what do you imagine? What does that look like to you? What treatments are a part of that? What treatments don't fit with that vision for you? And think about how we talk about it with families, how we communicate with the care team about it, really how we get started on comfort care. So if you would take a minute, just pause and really legitimately answer those questions. I'll pause for a second here. Okay. So welcome back from your pause. When you think about comfort care, does that include in your mind morphine infusions, handmade quilts, snack trays, holding hands at the bedside? Does it include physical therapy and occupational therapy, feeding tubes, antibiotics, BiPAP? Does it start with a hallmark family meeting? Or does it start when someone's on high flow and doesn't want to be intubated, but we're exceeding the limits of their respiratory comfort and need medications to ease symptoms? So some things to think about, and we'll address some of those more directly as we go through the lecture. So comfort care made the news a couple of years ago, and I want to bring this slide up to really look at the ideal of comfort care. So just before Barbara Bush died, she did something that was really pretty remarkable, and that's, as a public figure, she announced that she was going on comfort care. And this quote that you see is from an article about that written by some leaders in palliative care, and it just illustrates that ideal behind comfort care. So it says, comfort care prepares us to face the last phase of our lives and creates space for us to reach out and connect. What comfort care really means is a different kind of intensive care, one that treats pain, strengthens coping, and opens lines of communication, love, and spiritual connection. And so, I think that's and what I want to highlight there is the intensive care part, right? So there's all this language about withdrawal of care. And I think the important message here is that it's really just a different kind of really good medical care, right? But here's, kind of the other side. And this is a perspective piece that's from around that same time. Actually, someone wrote after that news. And it highlights some of the pitfalls, particularly in our communication about care at the end of life. Um, and, it actually uses a case in the article as well, where it talks about a patient who who is dying on BiPAP and is actually quite comfortable on BiPAP. And as the care team is talking about comfort care, and really pushing to discontinue BiPAP for this patient that is comfortable with that intervention. Oops, sorry about that. So, and I just want to read this quote from the article as well. So when patients are labeled by clinicians as receiving comfort care or comfort measures, there's added risk that they'll be treated without individualized care plans, which is what palliative care is all about, right? So individualized care plans that link medical condition to values. We have witnessed such unintended consequences as initiating continuous morphine treatment in a dying patient with renal failure, or deactivating a dual chamber pacemaker that has been supporting cardiac output. End of life care plans must be specific to the patient and family, reflecting their values and goals for that critical event and universal experience. So, should we change the name? Is that going to address the issues that we're having? And I think analogous to changing the name of palliative care, I think really the answer is we just need to be clear in our communication. I think it goes beyond a name, but just clear in our communication about what we're doing and why. So there's room here for terminology in the future, and hopefully some of you will be a part of really as a field solidifying that. But I think as part of our communication with our Vital Talk skills, here's some language that can be helpful. So when comfort care becomes our focus above all else, we start a plan called comfort care. And this means that we'll be proactive in treating symptoms, using medications and support from the health team. We'll start any treatments or medications that help your loved one be more comfortable, including, and list those. We'll stop medications or procedures or tests, lab draws, or artificial life support that aren't contributing to comfort. And then go on to address some specific, some common questions or concerns that people have at end of life as well. So addressing artificial nutrition and hydration early on, right up front, as well as addressing concerns about euthanasia. And when I say concerns, sometimes that's people requesting or demanding it. Other times it's people worried that their loved one might be euthanized. So let's take a look at kind of the evolution of comfort care order sets, again, using the University of Washington as a model. So we'll start with a case. So this is a stock photo, not a real patient, but representing a patient that with a familiar story. So this is an 87-year-old woman, we'll call her Miss Maggie, has a history of moderate dementia and heart failure, slipped and fell into a scalding hot tub that she was filling for herself, had severe burns on her back, thighs, arms. She was already on comfort care in the hospital at the time that the palliative care team was called. And palliative care was asked to help out because she was in severe pain despite high doses of morphine infusion, and the team just didn't know what else to do. So when the palliative care physician walked into the room initially to assess her, she found that when she barely whispered her name and moved the sheet to examine her legs, Miss Maggie grimaced, moaned, tried to pull away. She was in very severe pain with even minimal stimulus. So, and in looking at the medical record, this is what was found. So prior to starting a morphine infusion, She'd been on a low dose of scheduled hydromorphone, and then hydromorphone as a PRN. And then given her consistent need, a morphine infusion was started. And you can kind of see here the progression of that on the table. So I want to take a second and just ask what's happening here. So we can actually make a specific diagnosis given her presentation and what we see with this table. And that is, I want you to look especially at this. So we went over the course of 3 days from 2 milligrams of morphine per hour to 85 milligrams per hour. And rather than seeing pain get better, we see it getting worse. What Ms. Maggie has is opioid-induced hyperalgesia. It's something that's, a time to be suspicious for it is when you see rapidly escalating opioid dose without relief of symptoms and often with worsening of symptoms, often associated with delirium, as was seen in this case as well. And there's more to it that's a topic for another time. But treatment includes opioid rotation and often de-escalation. So the question for today, though, is how did we get here? How did we get to this point with her? And again, kind of a common story. So here's an example of the order at that time and how to adjust the morphine infusion. And I want to highlight that this was an infusion that, as long as the patient was symptomatic, having more pain, that infusion could be increased by 50% every half hour. And we'll talk more about the pharmacokinetics and why that's problematic later on. But, then the question came up, is this, specific to the University of Washington? Is the University of Washington unique in that regard, and found actually that many of the other hospitals in the area had similar order sets. And it was the case for general floors as well as in the ICU for vent withdrawal. That was my experience in Boise, actually, not knowing about this at the time, but going through a similar process later on. And now in my new practice setting, I saw a case like this last week where someone used some outdated orders very similar to this that still just happen to exist in our system. So historically, there's a long history that I won't go into great detail about, but many of these order sets came from ventilator withdrawal protocols. And so they include aggressive dosing and are heavy on drips because many of these patients are already on continuous infusions in the ICU while on the ventilator. There was a Cochrane review a few years ago that really shows, though, when you look across the country, that this care with comfort care order sets, and particularly with infusions, ends up not being individualized care. It's cookie cutter care, and yet it's widely variable. So very different in different systems, and even patient by patient, just a lot of subjective titration. And utilizing very, very high dose opioids. Also, as that Cochrane review was coming out, here's a quote from Fast Facts by David Weissman about opioid stewardship. And he says, a new report found that morphine infusions frequently did not follow accepted pharmacologic principles. Palliative care specialists have a responsibility to ensure that opioid infusions follow exacting standards that respect opioid pharmacology so that infusions cannot be confused with assisted suicide or euthanasia, a common misconception that persists to this day by both healthcare professionals and families. And so I think we've all seen that, as we introduce ourselves to teams, and we have a lot of work to do to continue to portray kind of the right image. So opioid stewardship is important for that reason, but also, we need to balance addressing symptoms as well I'd just like to highlight in this case, though, was Miss Maggie comfortable? And I think despite the high opioids, she was not. So we also, um, as the system and the setup at that time failed her in making her comfortable. And we can do better, and we'll talk about how we can do better today. So I'm going to go quickly through this, but this is just to highlight that as they reviewed this and came up with a new process, it was a new order set. It was an interprofessional process with leadership from a number of areas. And this next slide highlights the same thing. So you'll notice, physicians, pharmacy, nursing, as well as, respiratory therapy. So a great interdisciplinary or interprofessional group. So let's use another case to talk about how we approach comfort care now, and how we approach opioid pain management. So we'll move on to a new patient, Miss Charlotte. She's 56 years old, retired teacher with severe COPD, lives with her son and her mother. Despite quitting smoking 5 years ago, she was diagnosed with COPD at that time, and her COPD has progressed. 2 years ago, started on home oxygen, and last year had repeated hospital admissions for COPD exacerbations, each one more serious than the last. During the current admission, she was actually on the ventilator for 2 weeks, was able to be extubated, but remains weak, delirious, and unfortunately her breathing is worsening again. So this is another, I want to thank Caroline Hurd again for this case, but this is a scenario that is familiar in a lot of hospitals. So after many discussions with the healthcare team and the palliative care team, Charlotte's family decides that her wishes would be to focus on comfort and allow a natural death. The interprofessional team transitions her to comfort-focused, her care to comfort-focused care, and starts the comfort care order set. And then we're going to follow through that course, both the pharmacologic and non-pharmacologic interventions. So we'll start out with some pharmacologic management and look at opioid selection for her. So a couple of things to be thinking about as we're starting opioids for a patient. Can the patient take oral medicines? Do they need an infusion? What's the dose and frequency? So, to start with, we'll look at what she did have some opioids ordered already, and you can review the use in the last 24 hours. We see that Ms. Charlotte had morphine immediate release, 7.5 to 15 milligrams by mouth every 4 hours as needed. She was using that about twice a day. And then also had IV morphine 2 to 4 milligrams every 4 hours as needed, and used that about once a day. I want you to note the range there and the dosing interval, and we'll talk more about that. So now I want you to go to the opioid decision tree. You should have a copy of that from the website or follow along kind of online. We'll go to some zoomed in views here. All right. So thinking about Ms. Charlotte, let's go through this. So first of all, will the patient be withdrawn from respiratory support or from the ventilator? No, that occurred a while ago for her. Right. So the next part is, excuse me, looking at opioid use in the last 24 hours. So is she on a continuous infusion? No. And then moving on, yeah, has she been on opioids at all, or is this an opioid naive patient that we're talking about? So yes, she has been on opioids. Is the patient coughing or uncomfortable with liquid meds? And what we're really getting at here is how effectively are they able to swallow PRN medications? This is a point at which it's helpful to talk about morphine concentrated liquid. So um, it's important to note that even an obtunded patient can often take and benefit from concentrated liquid medicines. Interestingly, you'll see morphine concentrate referred to frequently as sublingual or written as sublingual dosing. Actually, it's not really absorbed orally or sublingually, or to a very minimal extent, about 10%. We're not sure why, but actually even patients who have impaired swallowing, who are obtunded, still do get some benefit from morphine. And one of the benefits over IV too is that that you get a more extended duration of action. So moving on, she's not coughing or uncomfortable with liquid medicines. And you can see there she's confused, but tolerating limited PO okay. All right. So we start out now with looking at the dosing and frequency more specifically. Note that, you know, if we go down this other path here, a patient who hasn't been on opioids, it's important to notice that there's no role for long acting. Okay, for a patient who for other patients who have been on opioids, typically we want to have a PO opioid available, again, even just for that duration of action, as well as an IV in cases where it's not feasible, or if you need a quicker onset, and we'll talk more about that. And then adjust the default doses if appropriate. So if someone's already using opioids and in the order set, they're using a different amount successfully than what's in the order set, going ahead and adjusting those doses. And then a time to consider a long-acting medicine, whether that's an oral long-acting medicine or transdermal, or even having a scheduled short-acting opioid. If they're taking PRN medications consistently and more than 4 times a day, that's a time to start thinking about a long-acting or scheduled medication. So it's important to think about the when planning for both the dose in terms of amount and frequency, it's important to understand what's going on pharmacologically. So we'll look here at morphine, but it's, you know, it's similar for hydromorphone or oxycodone. So and it's also important as we look at this to remember when looking at an outpatient regimen where you're talking about pain from an injury or whatever, where in that case you want to provide some pain relief, but the priority is really you know, longevity still, and protecting against some of the adverse events that can happen. Remember that we're talking about patients where relief of symptoms is the priority, even over safety concerns. And obviously we want to be aware of safety, but really our priority is making sure that this person isn't suffering. And so we're going to select different frequencies. In this case, really looking more at the peak effect than at the duration of action. So just to go through this, oral morphine, immediate release. Typically, it says onset of action 15 to 60 minutes. Um, I think for many people, you're looking at half hour-ish at least. It takes 1 to 2 hours to get to peak effect, and the duration is about 4 to 5 hours. IV morphine has a more rapid onset, and that's something to consider in the context of what's going on with the patient too. Um, are they likely to need to have times where they just need some quick relief? Then IV is preferable in that setting. The onset of action is 5 to 15 minutes, and for many patients, that ends up being around 10 minutes. Peak effect is in 15 minutes to an hour. And the duration, although off standard dosing for many patients is about 4 hours, whether you're using IV or PO. It's often a bit shorter as far as what patients experience with the IV morphine, so 2 to 4 hours. So if you're waiting for that 4 hours, you may really be getting at kind of the tail end of the effect of their prior dose. So returning to Ms. Charlotte's case, I want you to think about, do we want to adjust the dose or the frequency of her morphine at this point? So you can see here as a reminder kind of what she's taking right now. So she's only used it twice daily. But again, looking at that peak effect, we want to maintain her comfort if things change. And remember, she's having increasing respiratory distress. So what would you recommend? So going to the order set at University of Washington, selected 5 to 15 milligrams. Often we'll look at dosing with about a 2-fold range, so that the nurses have some room to have flexibility in dosing depending on the situation. The way this is built, it's a 3-fold range. But what I really want to highlight here is the interval. So every 2 hours, and again, that's so that you can dose at time of peak effect. So first of all, how she's responding when that effect from that dose is as good as it's going to get. Also be able to dose more frequently and not have the peaks and troughs to the extent of a longer dosing interval. It's important to, when you look at these PRN, make sure wherever you are working that if it defaults to pain, as it often does in many settings, just remember we often want to include dyspnea as well, specifically in this case for Charlotte, but for many patients when we're talking about care at the end of life, dyspnea can arise as the body goes through changes, pulmonary edema, and other issues come up that may not have been present before. Okay. So we elected morphine every 2 hours. And again, notice that this is the concentrated liquid for the oral dosing. So what would we do for IV dosing? Again, take a look at the peak effect there. She's only used it once, but we want to have the ability to respond quickly as her health changes. So again, she has done well with the 2 to 4 milligrams. The range in the order set in this case is 2 to 5. But here's the important thing to call out is the dosing interval of every hour. Again, looking at that kind of peak effect. So things to consider also in making choices of opioid for patients. One is that if they have a severe liver dysfunction or renal impairment, you may need to reduce the dosing. In the case of the liver metabolizes most opioids to some extent, and the kidneys are involved in excretion of those metabolites. Um, you may also want to reduce the dosing for patients who are elderly, and they may be more sensitive to some of the side effects, similar for patients with brain injuries. And then think about an alternative to morphine in renal impairment, as we mentioned above. But one of the issues is that some opioids, morphine is most famous for this, can have toxic metabolites. And so you can end up with worsening neurotoxicity. Really, some of that opioid-induced hyperalgesia can be more of an issue in a patient with impaired renal function on morphine, because some of those metabolites can contribute to that. And so in a patient who, it's not that anyone with any degree of kidney dysfunction shouldn't get morphine, but you should really think about using alternative for a patient whose creatinine clearance is less than 30 mils per minute. There are some alternatives where that's not an issue. So hydromorphone can also have toxic metabolites, hydrocodone. The two that really aren't significantly affected by renal impairment are fentanyl and methadone. But I'd also like to call out oxycodone can be used as well in a patient who's swallowing well. So the duration of effect may be a little longer. So kind of standard dosing of oxycodone is every 4 hours. In this case, we're talking less when we're dosing to peak effect. But it's important to know, maybe in other care settings, that oxycodone doesn't have the toxic metabolites that morphine and many other opioids do. You may just need to extend the dosing interval because it remains active a little longer in the case of renal impairment. So instead of a standard 4-hour dosing in an outpatient setting, you might be looking at 6 hours. And then consider increasing the dose by 50%. For someone who's still having active symptoms where what we're doing right now isn't cutting it, or if they have a anticipated or history of high opioid tolerance. So let's look at some non-pharmacologic needs for a minute. We'll step away from opioid dosing and we'll come back to that in a minute. But when we think about discomfort, there are a lot of things that can contribute to that and that we should be thinking about before jumping to a medication. So Ms. Charlotte is comfortable over the course of the morning. She starts to breathe faster, about 25 breaths per minute. Her son tells the interprofessional team that he's worried his mother is uncomfortable. How would you assess whether Charlotte is comfortable? And what anticipatory guidance can you give to the family? So think about, as before we go on to the next slide, how you assess comfort in a patient who can't talk to you. And I want to highlight that this is a really important skill for all members of the palliative care team. First of all, because we're not all in there at the same time every time. And so being able to kind of report back to the rest of the team and discuss it or highlight it for that nurse, hey, this patient is in distress. But beyond that too, not all treatment is pharmacologic, right? So that chaplain or social worker or nurse in the room might be the person who's best suited to managing the pain. So let's look at some pain assessment tools that are often used in nonverbal patients. And I'm not going to go into the details of this today. As you can see at the bottom, these are scales that are often used in critical care. But the important takeaway point here is really that facial expression and activity or movement, guarding and muscle tension, Those are the cues that are most consistent across these scales, and are really very useful at the bedside in palliative care. Um, so, for facial expression, you want to see that someone's face is nice and relaxed, or, if we're looking for distress, you might see brow furrowing, you might see clenching of the jaw. You might see, as far as activity or movement, you might see withdrawing, you might see bracing or guarding. You might see just general muscle tension, hunched shoulders. You may hear, as far as verbal cues, you may hear some moaning or some grunting with breath. And as you go through, it's not that these other signs are unhelpful. It's just that they really become very non-specific for discomfort. One that I want to call out is it's really common in a lot of order sets to see respiratory rate as part of the parameters for dosing your opioid. But a lot of different things at the end of life can contribute to an elevated respiratory rate. So yes, elevated respiratory rate can be associated with pain, but hypoxia can contribute to that. Acidosis, which is common, again, at the end of life. Hyperglycemia, and a number of other kind of metabolic derangements can lead to an elevated respiratory rate in the absence of discomfort for the patient. Autonomic changes like sweating, flushing are also common at the end of life, even in the absence of discomfort. So again, these cues of facial expression, restlessness, guarding, muscle tension are really important. And in counseling families, those are things that families can also watch out for. So say, talking to them about, we'll be watching for your patient, for your family member's comfort or your loved one's comfort. When we're not in here, if you see these things, let us know so that we can treat those symptoms. So other issues oh, sorry. I got, oh, there we go. Sorry about that. So before giving medications, we can look at other causes of discomfort too. And you want to treat for reversible causes of discomfort. So it's important to think about positioning. Is someone's neck like this when you walk in? Do they have dry lips, dry mouth, dry eyes? So we use moisturizers and ointments for those things. Are they constipated or obstipated, impacted? And I think, that's a tough one where we don't want to be blasting someone with a potent bowel regimen in those final hours of life. But if someone's hanging out for a little while, constipation can be really uncomfortable. So finding that balance. Are they lying in soiled linens? Do they have wounds that need to be attended to? Is there urinary retention? And it's important to remember that even in a patient who is voiding, overflow in the setting of urinary retention can happen. So they may be really distended and uncomfortable and still having urine. So thinking about in a patient who's uncomfortable, examining or thinking about a quick ultrasound to check for urinary retention. Adjusting the environment. So is it an overstimulating environment? Do they have appropriate lighting, temperature? And then think about utilizing complementary therapies as well. So things like music therapy, aromatherapy, massage therapy can be very comforting. So if you have those modalities available where you practice, think about those. Also, it's worth, as I mentioned before, talking about artificial nutrition, hydration. This is an issue that comes up a lot, and you have a great lecture that covers some of this counseling on this. My purpose here is to inform the medical decision making and inform your discussion. So back to Ms. Charlotte. Over the next few days, she has periods of discomfort that respond well to the PRN doses of oral opioids, um, and some acute episodes requiring IV morphine. She was still eating small bites of food, but now is barely taking sips of water, so she's progressed. Um, Her mother tells the interprofessional team that she's worried that she's starving her daughter to death. She's asking for IV fluids. What will you say to Charlotte's mother, and would you offer IV fluids? So this is maybe another time to pause and really think about that. What would you say, and would you offer? Okay. I think as we kind of go into this, this is an important point to check our own biases as medical professionals as well. Um, and again, thinking about what goes in that box for comfort care. I think historically there are a lot of order sets, as we're talking about here, that are very specific about what will and won't be continued. And I think looking at the individual patient and situation is important here. As a starting point, though, I think it's worth highlighting that starvation is a powerful word, and it's okay to clarify the important qualifiers in that definition. So it's suffering or death caused by having nothing to eat or not enough to eat. So that reassurance that, of course, we will be offering food and drink to your loved one, and then more of that conversation, as you'll uh, hear about in your other lecture, about what the body needs at the end of life, and that obviously we would not withhold anything, um, but that the patient may not be physiologically up to eating or drinking. I think there tends to be a lot of focus on, from the clinical side, on futility, right? And futility data often informs the decision of the medical team about artificial nutrition or hydration at the end of life. In this study, we can see that, with that placebo hydration compared with a liter a day hydration, had really pretty similar outcomes in terms of overall survival. And so it's not really contributing in that way to the patient's care. On the other hand, on the other side of futility, there's it's not all about survival, right? So this quote's from a study on the meaning of parenteral hydration to family caregivers and patients with advanced cancer on hospice. And really what they found in that study is that patients and caregivers hoped for improved symptoms, quality of life, and dignity. They weren't counting on a cure or prolongation of life from these therapies, but they were just hoping that it might help their loved one feel better and contribute to quality of life and dignity. So this quote says a lot. My hope is that it means improving her quality of life. That's my biggest hope. It's been a little bit a ray of hope to prolong her life of dignity, hopefully to sustain, to give her back a little bit of nourishment and put fluids in her body to help her along with her medication. So, some guidance in terms of artificial hydration and nutrition. In general, again, highlight that we always offer it. I recommend having a diet, even for someone who's been NPO due to dysphagia. Recreational eating, tasting sips, small syringe. Oral care is important too. So, having that moist sponge can really make a difference in using other mouth moisturizers. Times to counsel family or talk with loved ones about, prolonging dying. And I guess, that survival curve I showed you makes, a question whether dehydration really actually prolongs dying, but it's something to bring up in terms of limiting interventions. Um, but it can contribute, if definitely in talking with families up front about, if we see that it's causing swelling and retention of fluid that her body's not able to manage at this point. If we see that it's causing problems with incontinence and having wounds because of it, if we see bloating, if we see that her breathing is getting worse because of swelling around the lungs, talking about discontinuation of artificial hydration and nutrition. So kind of along those lines, speaking of it in terms of a time limited trial. So for a family that's requesting that, considering acknowledging that and saying, hey, these are the things that we would look for that would let us know that it's not contributing to her comfort or well-being. So shifting gears, we're going to go back to management of opioids after that foray into non-pharmacologic management. So back to Ms. Charlotte's case. In the following days, Charlotte is requiring more frequent doses of both liquid oral morphine and IV morphine for breakthrough symptoms of dyspnea, grimaces, and restlessness. Her family tells the interprofessional team the medications seem to be wearing off after only an hour or two, and our nurse worries she's coughing with the liquid morphine. So what is your next step? So I want you to pull out your opioid decision tree again. Let's return to that. And let's think about Ms. Charlotte now. So we're back at has the patient been on opioids in the last 24 hours? The answer is yes. And is she coughing or uncomfortable with liquid meds? And the answer is yes. So then we move on to, does she meet one of the following criteria? So unable to take a scheduled opioid, required 4 or more PRN doses within the past 2 hours after withdrawal of respiratory support, or requiring PRN opioids every 2 to 3 hours or more frequently. So we see that she is requiring the opioids more frequently. And so an opioid infusion is indicated at this point. So you start a morphine infusion based on her use in the previous 24 hours. So let's take a look at her opioid use in the last 24 hours. So she's had 15 milligrams of oral morphine 5 times for a total of 75 milligrams of oral morphine. And again, we, especially when you're using different opioids or changing administration form, we'll do these calculations a lot. And so we need to think about, as we look at the oral morphine, what that converts to in the IV form. They're not equivalent. So if you'll recall that that IV morphine is 3 times more potent than oral morphine, so a 3-to-1 conversion. She's had 75 milligrams of oral morphine with that 3-to-1 ratio, oral morphine being or IV morphine being the more potent. You divide that 75 milligrams by 3 and get 25 milligrams IV. She's also had some IV morphine, so 4 milligrams of IV morphine over 6 doses. And so 24 milligrams of IV morphine. So you sum the two, and in total, she's had 49 milligrams of IV morphine. We are doing a continuous infusion, so you want to administer it over 24 hours, and so you just get your hourly rate by dividing by 24. In this case, it makes it pretty easy for us, and it's 2 milligrams per hour. I also want to call out that it's important that you continue to have PRN medications for breakthrough symptoms. So we're starting this to kind of cover the need that we're already seeing with her PRNs, but then as symptoms change or she has breakthrough symptoms, we want to be able to address those. So make sure not to discontinue your PRN medications. And you may adjust the dosing of those, and we'll get to that in a minute. So now to titration. So Charlotte is still uncomfortable 2 hours after starting the infusion. When is the soonest you should increase her infusion? I'll give you a minute. Okay. So you should wait 8 hours at least, and you may see some even more conservative approaches. But why so long? Why do we wait 8 hours when she's having distress? And the answer is that she's not at steady state with the medication yet. And it takes about 4 to 5 half-lives to get to steady state. So when we think about the half-life of IV morphine, it's about 2 to 4 hours. And so she's not at steady state for at least 8 hours. I think the important take home here too, or the bottom line, is that relying on an infusion and rapid titration of an infusion alone leads to underdosing initially. So let's say that she's getting 2 milligrams an hour, and you even double that to 4 milligrams an hour. That works very differently than just getting that bolus of another 2 milligrams, right? So that infuses in very slowly. She doesn't get immediate relief. She remains in distress. And what you end up doing is underdosing up front and leaving someone in distress. And eventually, as you've ramped up the infusion rate, you undertreat up front and you eventually overdose the patient later on when you get to steady state. So overall, a better approach is, wisely choosing your rate, and you can see that we did that based on prior use. Sticking with that, or we'll talk about some of the times you might adjust it, and then making sure that you have PRNs to address symptoms now and inform your titration of the rate later. So here is the new, or here are the principles of the new algorithm. So you want to titrate around the time of steady state, right? So try not to make adjustments short of that. If you do, I would make those adjustments, and we'll show this. You want to make those adjustments based on PRN use. So if requiring a lot of boluses, you can maybe do some math and extrapolate and adjust your rate earlier. But in general, you want to look at not making adjustments until you reach steady state at 4 to 5 half-lives. Use PRN dosing based on earliest time to peak effect. So for IV, you want to do about every 15 minutes. So when we talk about our PRNs at this point, we want to be doing every 15 minutes. And you can escalate that dose. If someone's not responding to that dose, then that dosing can be escalated. And we'll see that on the next slide here. So I'm not going to go through this whole algorithm today, actually, because it's going to vary a little bit from institution to institution. So for those of you not practicing here at University of Washington. We won't go through it in detail, but a couple of really important key points or principles to look at. So again, once you set the rate, you're relying on boluses. And so your bolus typically to start is going to be the same as your hourly rate, but that can be given every 15 minutes as needed. If you find that you're stacking boluses, so a patient is needing more than 2 boluses in the course of 2 hours, then you can increase the bolus. If you find that they're still needing frequent boluses, then you may, with specialty help, you may consider you may consider increasing the infusion. As an alternative, in this regimen, it talks about increasing it by 50%. Or you could also, at that point, kind of recalculate how much they're using over how much time and adjust your infusion rate that way. There are protocols that do that. But again, the bottom line is once you set the rate, you rely on your boluses. You don't ramp up the rate, which is not only safer, but more effective for the relief that a patient needs right now. And then from that point, once you start this, the dose they get in boluses informs your rate changes later on. So it's much more responsive to patient need than what we saw with the original protocol. I want to call out a kind of a special case here. So this is an algorithm that can be found on CAPC. I'm sorry, I forgot to include the reference here. But this is from their tools for relief of dyspnea in patients with COVID-19. And the reason I'm calling that out here is one thing that I've seen a lot is patients who want treatment and are hopeful for recovery from COVID, and this can be applied in other settings as well, but I'm seeing a lot of it with COVID. So it's patients who are hoping that they can recover, yet have elected to have elected DNR, DNI code status, right? They realize if they get to a point where they're intubated, they're unlikely to have the functional outcomes or the survival outcomes that they're hoping for. And so have elected that. But otherwise, they're on high flow oxygen, and when people are getting to the limits of what we can provide in respiratory support, the symptom management becomes really important. And I often tell patients, hey, if we're going to do what we can to get you better. If your breathing gets worse despite that, and we're not intubating you and respecting those wishes, then what we'll do is use medicines to ensure that you're comfortable and don't feel like you're suffocating if the oxygen at maximal doses isn't providing you that relief. And so this algorithm just kind of goes through, first of all, is the patient hypoxic? And you start out with addressing things from a standpoint of respiratory therapy, right? But then if they have symptoms, and you start out with the 2-hour oral dosing and 1-hour IV dosing like we talked about before. I think if people, this says, is patient on comfort care or actively dying? I think when you get to a point where people are in distress on that 50 liters of high flow, that I often recommend that we use a more aggressive kind of comfort care approach. And this is one thing I alluded to earlier on in the discussion, where you may not, up front, we've talked about this, but you may not have a family meeting and say, we are starting comfort care. It's that they have symptoms that aren't managed by the primary treatment of their respiratory failure alone. And they're going to be in severe distress if we don't manage those symptoms. And so it's kind of, you kind of get pushed into comfort care. I have seen patients recover from this point where I've thought they were dying. They use the opioids, that eases their work of breathing. And then they continue with treatment and get better. But I also tell, counsel patients to be prepared. If we need to use these medications and their breathing continues to get worse, that their prognosis will be short. But I want to highlight here that every 15-minute interval and with doubling the dose if they don't have response at a given dose. And then it's dose finding similar to what we talked about, but in a more kind of rapid and aggressive format, just because of how symptomatic these patients can become very quickly. Back to non-pharmacologic needs for a moment and counseling families. So, and I want to take a minute just to highlight signs of imminent death. So if you can bear with me for a couple more minutes, we'll wrap this up. So Miss Charlotte's now comfortable on the morphine infusion. Her family asks, how much time does she have left? What guidance will you give the family? So this table goes through some specific signs of approaching death. These are things that you hear about commonly. They can help us predict or give the family some guidance. First is the death rattle, and it's as you can see in the presence before death, it's present about 35% of the time. So I tell families not to expect it, but that they may see it. And it often occurs in the final days of death, but may still be several days. One that I added here, and I've heard and seen published a couple of different numbers about this, but diminishing urine output. So, if your patient has a Foley in as a part of their comfort care and you're able to look at the urine output, that can be helpful. I've seen in this case, the one I included here is urine output less than 100 mils per 12 hours, or I've also seen if it's less than 50 in an 8-hour shift, then that's predictive of a prognosis of less than 72 hours survival in the one I mentioned earlier, and in the case of less than 100 per 12-hour shift, 48 hours, up to 48 hours survival. Occurs about 50% of the time before death. Some that are really specific. So this one's actually very helpful if you're able to track it. Another one that is very helpful to know that you're kind of right there is mandibular movement. So it's present about 95% of the time before death. And you're looking at the last several hours, they say about 8 hours. So, and this mandibular movement, some people call it guppy breathing. There are a number of different names for it, but it's a very specific, I can't do it very well because my jaw is already kind of retracted, but with the in-breath, you see the jaw kind of retracts and opens and goes down with each breath. So once you are familiar with it, it's a very clear sign that someone's in those final 8 hours or so of life. Peripheral cyanosis, or people talk about duskiness, about 5 hours, present about 80% of the time. And another one that is really helpful is loss of radial pulse. So if they've had, as you start comfort care, if you check for that, they have a radial pulse. The next time you see them, they don't. It means you're very, very close. I actually saw that this morning in a patient. But it can be tough to catch depending on when you're rounding and how you're rounding. I won't go through this in detail, but basically, it's important in other settings to have standardized approaches. I think hospices do a really great job of having standardized order sets and processes to meet these needs. You can think more creatively about routes of delivery. So sub-Q rectal is very effective for a lot of oral medications and not used very often. Another important one that we don't think of often in the hospital is transdermal. So a lot of medicines, including opioids and benzodiazepines can be administered transdermally. Often you just need a slower rate, and we'll want to use a, a more concentrated formulation if volume is an issue. And there are specific transdermal buttons that can be used, or you can use an IV. So you just want to use a small IV at a 45-degree angle and secure it. They can be used longer than IVs and are much more comfortable for patients. So something to think about even in the hospital for that lingering patient. Other resources. So you'll notice that we didn't get to a lot of other symptom management in terms of anxiety, agitation, delirium, constipation, bowel medications, nausea, vomiting, antiemetics. Those are each lectures unto themselves, but important in looking at comfort care order sets as a whole. So you'll find the resources on Canvas to link to those and get more information. And then, it's important again to be systematic about it. So looking at and be clear in communication, as we talked about at the beginning. So this is an example of a provider checklist, and then also a nursing checklist. And then the parting thought I want to leave you with actually is that we have a lot of evidence now for how to do this well, and practice is improving, but it is really hard to find practical order sets that put this all together that aren't at an individual institution. So if you look at CAPC and you try to search comfort care order set, really hard to find something. Similar with AHPM. People will talk about them in forums and so forth. But really, I think when it comes to a whole encompassing package for comfort care at the end of life, a lot of systems are still working out all of these things that we've talked about on their own and reinventing the wheel. So a challenge, as you go out there and become like the best palliative care interprofessionals ever, is to look at ways to improve and have better kind of national standards and practices. There are a lot of very popular sources, as I mentioned, that remain outdated as well, including, when you look at some of the fast facts for ventilator weaning comfort care, those are things that were written 10, 15 years ago. And as a field, we can improve. So again, a challenge to go out and improve it. I want to thank everyone for your attention today. Let's go out, take excellent care of our patients, and make it better for all of us working in the field, and easier to provide this quality care. So thank you. I also I want to thank the team that put together the order set at the University of Washington and their expertise, and others who were involved in that work. So thank you. Bye, everyone.